We're now going to hear perspectives from the physician delivery side, then the hospital system, university center delivery system side, and then finally from Wall Street. So I am actually quite proud to be included among our next speakers, colleagues, and friends. Robert Margolis is co-chair of DaVita HealthCare Partners and CEO of HealthCare Partners, LLC. Bob has been on the leading edge of managed care industry for more than 30 years. He serves on the board of several prestigious healthcare organizations, which you can find in your syllabus, but those include being immediate past chair of the board of National Committee for Quality Assurance, NCQA, past chair of the board of the California Association of Physician Groups, CAPG, and a founding board member of the Council for Accountable Physician Practices, CAPP. But most importantly, and if you don't cover this in your talk, it'll be the first question in the Q&A, what's happened to your handicap since you joined DaVita, is what I want to know.
Thank you, Jay, and good morning, everyone. As Jay well knows, there's no chance I will ever match his handicap. It's a pleasure. Margaret and Paul, thank you again for another invitation. It's a lovely opportunity to talk about some of the things that we're passionate about. And Chris was an excellent lead-in because those of us that are so devoted to population health management understand that incentives drive behaviors, and to have employers engaged on the demand side to actually encourage employees to use the healthcare system well, and then providers, delivery systems on the supply side to actually deliver high-quality, value-based care is a wonderful opportunity to actually combine the efforts that will ultimately improve health care for Americans. So this morning, I thought I'd talk a bit about HealthCare Partners. I get a lot of questions about what was this thing about DaVita HealthCare Partners. I'll mention that. But basically, I want to just talk about HealthCare Partners only as a microcosm, as a case study perhaps of one alternative, a scalable alternative, we believe, towards a national healthcare transformation to higher quality, better outcomes for patients. That's the business that physicians and clinical caregivers and clinical teams are about. Today's a really big day. Many of you probably are not paying attention, but we sure are. CMS is due to come out this afternoon with their announcement on the next year's cuts for MA. MA, Medicare Advantage, has been the lifeblood of most integrated healthcare systems, certainly in California, and got whacked pretty good last year, and it's going to get whacked again this year. So efficiency, high quality support, and care teams, which is the essence of what we believe in, are under continuous pressure. And so I thought I'd talk a little bit this morning about where we see physician clinical leadership perhaps helping to take this thing forward, a little bit about what we see happening in other models of delivery, because we're certainly not the only one. So what I'd start with to say is that that the transformation from volume or fee for volume to fee for value is here to stay. It's inexorable. It's going to come across the country. And those that can lead that transformation, those that can really get on the value side. Now, value is always described or historically described as quality plus patient experience divided by cost. But those of us, again, recognizing the constraints on revenue, understand at this point, most people are most concentrated on cost. There's almost no consumer recognition of quality differential in the choices they make. That's a future opportunity. It's an enormous opportunity, and I hope that all of us in the healthcare delivery space will continue to really monitor and improve the kind of quality outcomes we have. But the game so far is still around cost. There's a tidal wave of activity going on around the country because of the ACA, exchanges, the opportunity in duals, especially in parts of the states that have embraced the dual experiments. Lots of new entries. You heard about those in the panels that you've heard before me. But, and this is, obviously somewhat selfish, I believe as a physician that physicians should and can, along with clinical teams, lead the way, and that if we don't, as providers of care, help design the system and are in the best place to actually deliver care, then shame on us. Others will enter the market. But first and foremost in there is the recognition that incentives drive behaviors. As you'll hear a little bit in my talk, I believe strongly that until we get to global capitation of organized systems capable of taking risk, that we will never get to an idealized system of managing populations. And I also would say that doctors, and I've had a long history of working with them, won't change behaviors until there's downside risk involved. And so this shared savings, this opportunity to get a few bucks if you do the right stuff is nice. It's around the edges. It's not the answer, in my view. So what's happening in our world? Hospitals are very active, as you'll hear from Terry. I don't want to steal any of his thunder because Terry's a great friend and runs a terrific hospital system. But what are hospitals doing? They're employing physicians too. Why? Primarily because in a population health world, a hospital that is only a hospital is a commodity. It's a vendor of services. It doesn't want to be left in that position. It wants to start to vertically integrate. Hospitals are taking on risk. There are multiple ACO experiments, mostly the Medicare shared savings, but also commercial experiments going on. And many of the bigger systems are now vertically integrating and trying to be Kaiser-like. They're getting their own health plan. Certainly we're seeing that. We see that with Sharp. We see that with Memorial now. We see it with Sutter, Providence, especially in the Northwest. And so those folks believe that ultimately they have to get as high up on the food chain as possible. There's clearly the knowledge that there are going to be fewer admissions, fewer bed days, and so involvement in post-acute and ambulatory care is a significant strategy that is being pursued. Payers, very much active as well. As we certainly know, Humana, Optum, others are very active in acquiring physician practices or helping to manage them. Others are being more of the back office for ACOs, the Aetna type model, somewhat the Cigna model. Why? They are bound by this 85% MLR rule in the ACA. It's very important for them now to participate in the savings that can be created on the delivery side as a way to continue to profit in a world where their premiums and medical loss ratios are constrained. So we'll see a lot of activity continuing in the transformation on the payer side. Physician side, that's us, aggressively consolidating IPAs, medical groups, other forms of consolidation or MSO, management service organization relationships. Taking on more risk. There's an interesting comment, it's not just physicians but hospitals as well, is there seems to be a specific inverse relationship between the desire to take risk and the capability to manage risk. But that, but that will play itself out with winners and losers, and my guess is that Cheryl might mention something about that. And physicians, of course, are saying in many parts of the country, we can't survive as individual or small practices anymore. We got to join somebody. And they're joining hospitals. They're primarily hospitals around the country, health plans as well, and some of them joining organizations such as ours. A bit about HealthCare Partners. And why we do what we do. Our mission, of course, is about patient care, quality, performance, helping physicians be as good and care teams to be as good as they can be. But our vision is that we're in a time of enormous opportunity to transform the American healthcare system and even international healthcare system. You may know that DaVita is in, I think, 11 other countries. And so the opportunity to be one of the catalysts for the consolidation and better performance and accountability of physicians is our dream, our transformation. Our history, you have these slides, is basically one of continuously doing this for the last 25 years, of looking for opportunity to work with more and more physicians and care teams, initially in California and then around the country, and our merger with DaVita last year, or 2012 actually. Yeah, that's a year and a half now. The business model, for those of you not familiar with HealthCare Partners, is very consistent with what I said earlier, and that is, to the greatest extent possible, it's taking full responsibility and risk for a big population, now about 1 million patients under full risk, both on the commercial and Medicare side, 300,000 Medicare Advantage members, which explains why we're paying attention to what CMS says today. And ultimately saying, okay, if we manage that risk well and we manage the patients well, there's opportunity in the very inefficient healthcare system that we live in to reduce waste and improve quality. And we measure that consistently. And our view, which I think is hard to debate, is that physicians and care teams make most of the decisions once the patient accesses us, and why I referred to Chris on the demand side as absolutely critical, is get the right patients to access the delivery system at the right time, is that there's just an enormous opportunity that physicians have to do the right thing by their patient, to fully engage the patient, to personalize the care, to do the other stuff that you heard about in the earlier presentations, but to do it in a very empathetic, patient-satisfying, personalized, satisfying manner, and to avoid an awful lot of the cost that is in the system that really doesn't bring value, doesn't bring benefit. Just a snapshot, we're now in those 5 states and serve about 1 million patients under risk. People ask all the time, well, okay, so why did you join with DaVita? I can tell you from the HealthCare Partner side and the DaVita side, from DaVita, being in pure kidney care, a pure clinical enterprise focused on serving 1 out of every 3 dialysis patients in the country, the opportunity for future growth in the kidney space was relatively limited. The beauty of transformational population health is that it's the beginning of a new revolution with enormous potential future supply of opportunity. So it was a big diversification possibility on the DaVita side. On the HealthCare Partner side, our vision was to be the leader in transforming American healthcare, and now we have our flags, through DaVita at least, planted essentially in every state, relationships with doctors in every state of the country, and the opportunity to learn what's happening market by market and to continue to grow. Both clinical enterprises, both very clinically oriented around measurement and accountability and quality and measurement, and just the right opportunity to live our vision. Whoops. What happened? It's all about culture within an organization. So how does the physician-centric approach work? Essentially, it's all about data. Our organization is data consumed. If we can measure it and we can monitor it, we can figure out the populations that we serve and how we can better assist by slicing and dicing subsegments of that population and designing clinical programs to meet the needs of those patients. So it's data analytics, then developing a supporting infrastructure, alignment through incentives, and integrated processes to make it happen. The big difference, and those of you in Southern California know this well, but around the country you don't, is that it's not a physician-only team. It's an enormous team of support, of care managers, of social workers, of physical therapy, of home care folks, of outreach, in order to have a fully defined team approach. So having 900 or so care management type resources to be part of a clinical team is the only way to manage, in our view, the population and create the results. I mentioned the technology. We are agnostic. All of the different systems need to be standardized to feed into a central data repository. The keys to that, of course, are to have information portals for the physicians so that they have great online access, ability to know exactly what the gaps in care and the opportunities for improvement are, health maintenance, patient online capability to access their care and their personal health records and edit, and the golden opportunity of the future still to be better defined as predictive modeling, is understanding who's going to be a resource consumer next year, not who was the one the prior year. That's improving. We're getting better at it. It's got a long way to go, but that really is the big strategic opportunity in population health. So some of the examples to finish up in my last 5 minutes that Jay tells me I have are just some graphs that you can just see where the efficiency lies. There's enormous opportunity in those at the most sick end of the curve. As we all know, 50% of health care, 52% is consumed by 5% of patients. So homebound patients, very active home care programs, as you can see, enormous reductions in ER use, urgent care use, and in hospital admissions as well. ESRD, which of course is important both to us and now more and more to DaVita, a comprehensive bundled ESRD program can show significant similar results. And you can do the calculations on the improvement if it's $4,000 a day in a hospital and you've reduced those number of admissions or ERs across, in our case, 300,000 Medicare Advantage patients. You see the opportunity. But measuring quality has an enormous impact, in our view, in the future, most for internal improvement and someday for consumer engagement. And we all also know that in Medicare Advantage, being a 5-star performer has enormous financial and marketing and enrollment opportunity, which we can describe later if you're not familiar with it. So clinical quality, never to be ignored, and the goal is to be at 5-star everywhere. I'm happy to say all of our key markets are 4.5-star minimum, shooting for 5-star. So focus on quality, focus on patient experience, absolutely critical. The big savings, people ask, where are the cost savings? And Terry will comment, I'm sure, about why the hospitals are doing what they're doing, is that there are an enormous overuse of hospital care if you focus well on ambulatory care and management and readmissions and post-acute care, to the tune of about a 40 to 50% reduction in hospital days in a population. Again, you can do the math, 300,000 MA patients at $3,000 or $4,000 a day across that kind of result gives you some sense of where the opportunities are in American healthcare to reduce cost, improve quality, and ultimately serve patients with distinction. I think you've heard enough of this over the last 2 days. Clearly, this is a transformation away from small practices to bigger practices, from fee-for-service to population health. Rigorous measurement, holding the doctors and the care teams accountable, working hard on patient engagement and patient satisfaction. That's the stickiness that keeps our patients in our network and keeps patients wanting to come back to us. Those are the key elements of the future. And then the last piece, of course, is if you really do have a growth strategy, you need capital. And DaVita, of course, brings that in greater extent than HealthCare Partners did alone. So where is it going? It's going, again, to this transformation from fee-for-service to capitation. It's going to be a long, slow trudge, we know, around the country to transform fee-for-service organizations and make that leap, that bridge from fee-for-service to population health, but we think we have some of the tools to do it, and the ACA prompts it. The ACA is very much aligned with ACOs and the others to do that. And basically getting physicians to just ask this question and care team is, what can I do to keep the patient healthy? That's the key. Conclusions, we think that there's a big opportunity here to move the world to population health. We think it's the right thing to do. We want to partner with employers and the government in ways that incent that change on the patient demand side and certainly on the delivery side. Big opportunities in the ACO world. We're participating in shared savings. We did in Pioneer. We dropped out of that for reasons I can explain if you wish, but have close to 100,000 commercial members in our commercial ACOs. So very much consistent with our philosophy that that is a step along the road towards capitation that we should take. And lastly, especially in some of the counties we serve, the dual eligible is an enormously poorly managed population that if we can bring coordinated high quality care to that population, the opportunity to improve care for sick, fragile, and poor folks is enormous. So we're very much hoping that the state gets that right and rolls it out appropriately. Thank you.